You may notice a theme that surgeons are uncomfortable in scrubs. But thank you so much, Shafi. And I have stood on this stage and talked about surgical robots. And today, I'm actually not going to talk very much about surgical robots. I'm going to talk about how do we make the next generation of surgeons? How do we bring surgery intelligent, digitally enabled, and underscore global? How are we going to address the lack of surgeons in low and middle income countries? So disclosures, Intuitive Foundation is the corporate foundation of Intuitive Surgical. So I'm an Intuitive Surgical employee seconded to the foundation. Surgery. We often think of it a bit as a luxury. It tends to be a bit of an afterthought in global public health. And I want to convince you that surgery should be considered a cornerstone of global public health. And why is this? We perform about 300 million surgeries a year worldwide. And yet billions of people lack access to even the most basic surgical services. That's 150 million surgeries a year that we are missing out on, that people need to put life and limb back together again. And this results in about 10 million potentially preventable deaths every year. And you put this in context, there's 10 million deaths a year from cancer. There's 3 million deaths a year from HIV, TB, and malaria combined. And yet in our global public health spending, we focus a vast majority of it on infectious disease. Now, I'm not saying we should not be treating infectious disease, and we should not be focusing on infectious disease. I'm saying we should not be ignoring surgery. Why do we ignore surgery? We tend to ignore surgery because it's hard to increase its scale. And I'm going to talk a little bit about that. So you were expecting me to come in and talk about surgical robots. And we can learn a lot from surgical robots. We can learn a lot in the process of figuring out how we're going to scale surgery. But the operating rooms that I'm in these days look a lot less like that last operating room and look a lot more like this operating room in Ethiopia, where I was in August. And we were struggling to get that electrosurgical unit working prior to a thyroid surgery. This is at that cutting edge of where we're missing people, where people have to travel too far to get to a surgeon. When they get there, the OR is under-equipped. They can only run a couple of surgeries per day out of this operating room. And when we think about where we're trying to solve this problem, a lot of the technologies we've been talking about have been focused on more high-income countries. But when we think about where is this problem that we're going to be solving in the future, we need to think about how the world is going to change demographically. So this is a population distribution, 0 years old to 100 years old in 4 different regions of the world. The green is the Americas, yellow Europe, blue Africa, and the red is Asia. And you can see that Asia has started to contract in terms of its population growth. Africa is still growing. Europe is contracting quite significantly. If we play a model forward and look at what kind of demographic changes are going to be happening, we see that we're having a population explosion in Africa. It is because Africa is becoming wealthy. The population explosion that happened in Asia followed getting healthy, and then they got wealthy. And so we go 70 years approximately in the future, and the world looks very, very different. And if we think in that kind of time frame that we're going to be able to train enough clinicians to meet that demand in the slow way that we train clinicians now, we have another thing coming. And so what does an exponential adoption of technology mean? When we look at the infrastructure for surgery, we tend to think of it as the buildings in the back. It takes about a year to build a hospital. It takes more than 10 years to train all of those clinicians that are actually going to be in that hospital. And if we're talking about demographic changes that are happening on the order of 300 million people entering the middle class in India alone in the next 10 years, we can't train at this pace of producing a cohort of surgeons in 10 years. And when you look at what a difference in adoption rate looks like when it can be exponential versus it can be linear, this is the exact same economies over the exact same period of time. And on the left is the adoption of cell phones. Very complicated to make where you make them, simple where you deploy them. Able to be done exponentially. It scales. Same economies, the number of medical doctors per 1,000 people over that same period of time. It's not that these economies wanted surgeons and medical doctors any less than they wanted cell phones. It's that our training process is linear, and we don't know yet how to scale it. And so when we're thinking about scaling surgery needs, of course, the hospitals, the infrastructure, where are you going to do it? It needs surgical practitioners of all types, not just MD surgeons, but anesthetists, nurse midwives, medical officers. Scaling surgery exponentially needs a radical rethink in education. How are we educating these surgeons, and can we get it off that linear path? We have successfully gotten reading-based education scalable. You can distribute books. You can read just about anything on your cell phone traveling around. We have scaled lecture-based education. We can make one lecture, it can get broadcast all over, it gets saved, people can read it or listen to it at different times. These have both scaled. What we haven't scaled is skill-based education. We still do it as an apprenticeship model. We still bring people centrally to, even though we've made surgical simulation centers, we bring them to that center, and we have a master surgeon educator looking over their shoulder and teaching them how to do these physical skills. This is the central tenet of skills-based training. See one, do one, teach one, the apprenticeship model. If we're going to scale, we have to shift thinking to see one, teach yourself one, and then go do one. Because the only thing that we have in huge abundance is the number of people out there who are brilliant and really good with their hands and really want to help their fellow country people. Those are the people that we need to be able to teach. And so when we think about what is this fundamental thing that we're trying to unlock, that scale is assessment. If you learn a musical instrument, if you learn a sport, if you learn surgery, you're doing a skill, there's somebody watching you, and they give you coaching. They give you feedback. If you can give yourself coaching, if the simulator you're working with can coach you, if there's a system that you're working within that can coach you, that can keep you from practicing poor skills and move you in the direction of excellent skills, we can scale skill-based education. So I did say we were going to learn things from robots. So we've been playing around with this in robots for a while, in that we can video a procedure, we can look at all the kinematics associated with this, and we can task deconstruct, and we can start giving people feedback based on that. And so when we run these through machine learning algorithms, we look at what kind of feedback can we give to the clinician based on the stage that they're at. What's exciting about this, and when we start looking at task deconstruction and understanding the difference between an expert and a novice, is that we don't need the robot in order to be able to do that task deconstruction. We just need video. We need the measurements of what's going on that simulator. And so I also believe in the prize model. And the Intuitive Foundation, we put together the Global Surgical Training Challenge, which challenged people all over the world, PIs from low or middle income countries, to come up with surgical simulator-based training for clinicians such that they could master a new skill at any point in their career from anywhere in the world. Take the training out of the medical school and put it at the point of care. Take it out of the hands of the gatekeepers and put it into the hands of the caregivers, who then can teach themselves this new procedure. And so we had participants from 44 different countries around the world, and there were 2 finalists that I'm going to, who won, shared the grand prize this past December. So this is the group out of Ethiopia, All Safe. You can see the very high-tech simulator that she's working on right there. You can make this simulator out of cardboard, you print out the instructions, and you have a laparoscopic training box. She's got her cell phone on as the camera and a laptop. All of the models that she's working on are made out of locally sourced materials. Where's the high tech? Where's the digital in here? The high tech and the digital is that she takes a video of the work that she's doing, and she uploads it, and she gets AI feedback on a whole checklist associated with the procedures that she's doing. She also has to look at other trainees' videos and give them feedback. So it's a very interactive learning process, but it takes the learners as a burden on the system and turns the learners into an asset on the system. She's a trained surgeon. She already knows how to do an open appendectomy or an open tubal ligation. She's learning how to do it laparoscopically. And in the months following this, she went and did her first cases in Cameroon under observation during the study. And there are about 12 people who are trained to do one form of surgery, self-trained on this new form, and then have gone on to clinical practice. One of the other teams did external tib-fib fracture fixation. This is a problem in low and middle income countries, people on the little mopeds. You get an open fracture of the shin. The 3 guys sitting in the middle there, the one on the left is the one of 2 orthopedic surgeons in a far eastern province of Nigeria. 2 orthopedic surgeons, 16 hospitals, 3.5 million people. The 2 guys sitting with him are medical officers. So medical officers get about 6 years of training. They are not MDs. They learn to do some basic surgical procedures like open appendectomies. There is no avenue available to a medical officer to learn an orthopedic surgery procedure. It is relegated only to surgeons. They were able to 3D print bone models. There are 4 places they could do 3D printing just in the city that they were in that province, and still only 2 orthopedic surgeons. Technology moves faster than our educational system. They were able to print the 3D bones. They learned how to do the external fixator. The orthopedic surgeon came and observed their first cases. This looks great. You guys don't need me here for this anymore. Send the patient on when they have a joint involved in the break. Being able to build modules like this, self-administered assessment, the burden of proof is on us that we can do this clinically responsibly, that we will not do harm, but that clinically trained people can teach themselves a new procedure. They can use the feedback from those simulators, from the digital environment that we put around it, in order to give them that feedback, and they can attain a high level of mastery. This is the way we are going to scale surgical education and meet this demand. Thank you very much.
Thank you. Thank you, Catherine. Just one quick question, if you don't mind. So amazing work, and you're actually one of the people providing the solutions that was kind of the challenge that was faced in 2015. When do you see the outcome of your work? Will there be an impact at some stage that we can look at metrics to scale it higher?
Absolutely. So the foundation is both has a program to continue to make new modules in areas that we think have the highest DALY count, disability adjusted life years. So what are the surgical procedures that if we made them much more widely doable would have the best impact on that population. And then I'm working with COSEXA, which is the College of Surgeons of East, Central, and Southern Africa, to bring out modules that are part of their fellowship exam. And so we're looking at, can we, in formal channels, increase the number of surgeons that are getting trained through that program? And then once that's been proven out with a lot of review of those trainees, it's ready to roll out more broadly into areas where we don't have that kind of oversight.
Great, amazing. Thank you so much, Catherine. Thank you so much.
Thank you.